Hello everyone, Medical Level Up here, and we're back again with another video. Today's video is going to be about STEMIs. Let's start off with the definition of a STEMI. So if there is ST elevation in two contiguous leads and you have symptoms lasting more than 20 minutes of duration, that's a STEMI, which is an ST elevation myocardial infarction. You can also look at the criteria over here for a STEMI in different age groups. Let's take a look at the changes that happen during an infarct. So you have ST elevation in the beginning over here. Then you have these pathologic Q waves forming. Eventually the ST segment tries to come down. You have a T wave inversion and a residual T wave, which could be positive or negative, and the persistence of the pathologic Q waves. Even if a PCI is undertaken, sometimes T wave inversion still persists, and this is known as a reperfusion T wave. Q waves can also persist in these cases. Let's look at type of ST elevations, because there's going to be different morphologies that you're going to come across. So the first one is a cannonball appearance. This is known as cannonball because it suddenly offshoots off the R wave, and it's something like this. The second one is a tombstone. So a tombstone is more or less like the headstone of a graveyard, and it's going to be something like this. So both of these are types of ST elevation. The third one is a plateau forming ST elevation, and over here you just get a plateau for the ST segment. The fourth one is a saddle shaped ST elevation. Now this could be either seen in a STEMI or other variants such as pericarditis, and it forms a saddle with the ST segment. Now, a good question here would be, where do you actually compare the ST segment to? Now, most people will tell you that you're supposed to compare it to the PR interval, but another good estimate is also the TP segment. So let's draw an ST segment elevation over here. We can see that the ST segment is higher than the PR interval, and at the same time it's higher than the TP segment as well. So you have the TP segment over here and the PR interval over here. These are two comparison baselines for you to see whether there is any ST elevation or not. Let's go on to draw a heart over here. We're going to draw the inferior leads, which are 2, 3, and AVF. These are the inferior leads. And the next, we're going to draw lateral leads, which are AVL and lead 1. Let's say that there is an infarct happening over here, which is shown by the gray color. What you're going to see in the inferior leads is going to be ST elevation, because that marks the territory of the inferior region of the heart. And at the same time, the lateral leads, which is 1 and AVL, are going to show you ST segment depression. Why? Because this is a mirror image of the same infarct that is happening in the inferior territory, and here you can see that it's manifested as ST depression. This concept is known as reciprocal changes, and it just signifies that the transmural infarct is actually quite large. Let's look at the chest wall cavity from the lateral aspect. You have the spine at the posterior aspect, and we're going to draw a nice little heart over here, the aorta coming out of it. Now in reality, you have a lead which is placed on the chest, known as V1, and an imaginary lead at the posterior wall. So this is V1, and this is an imaginary lead that we have created. This concept is very important later on. So let's say you have an infarct happening over here. What V1 is going to show you at this point is ST segment elevation. And the imaginary lead, which is basically a mirror image of lead V1, is going to show you ST segment depression. Again, this is simple reciprocal changes, but this is very important in understanding a posterior STEMI later on. Let's look at ST elevation versus ST depressions now. Now, the mechanism by which ST segment elevation is created is poorly understood, but when you have a transmural infarct, the ECG tends to show you ST elevation because it tends to maybe retain the current, or the current is seen going towards the lead. So in this case, you're going to get ST elevation since it's a transmural infarct and the current is actually directed towards the lead. If you have subendocardial ischemia, which is only in the endocardium, current passes relatively normally through the rest of the myocardium, but this portion of the myocardium retains the current and it is directed away from the lead, and hence you get ST segment depression. That is one basis for how you get ST segment elevation and ST segment depression. So with elevation, you've got a transmural infarct, and with depressions, you've got subendocardial ischemia. This is also very important when it comes to seeing an ECG when you're doing stress testing. Let's expand on that point. What happens during a stress testing is that the heart rate tends to go up and the oxygen supply and demand has a mismatch, and that is why you can detect any changes of ischemia on the ECG, which will give you a positive stress test. So a positive stress test will produce ST segment depression, which is more in the form of a plateau, as seen here. So you're getting ST segment depressions and a faster heart rate, and this is in the shape of a plateau. The second type is going to be an ST segment depression, which is actually downsloping. This is also considered a positive stress test. On the other hand, a stress test is considered negative if there is an increase in the heart rate, but there is ST segment depression, which is basically upsloping, kind of like this. This is not considered a positive stress test. Now, in another situation, what's going to happen is that there is a false positive stress test, and this basically happens in conditions where there is a patient who is on digoxin therapy, he's got left ventricular hypertrophy, Wolff-Parkinson-White syndrome, or he has a pacemaker in situ. There are a couple of special topics associated with ST segment elevation, and we're going to be discussing them shortly. The first one of these is a hyperacute T wave, but this is going to be more related to T wave in V1. This concept is known as loss of precordial T wave balance, which basically states that a normal T wave in lead V1 is supposed to be more or less inverted. The alarm bell should start ringing inside your head when the T wave is upright and is new in lead V1, or the height of the T wave should not be more than the height of the T wave in V6, as shown here. This is basically known as a hyperacute T wave, and this is called loss of precordial T wave balance, which is a precursor to a STEMI. Another one is Valence Syndrome, which we'll discuss shortly. De Winter T waves. Both of these things are STEMI equivalents. And an RV infarct. Now, if you take a look at the ECG, it's not really a good tool to show you what's happening with the right ventricle or the right side of the heart. Imagine that you've got a heart over here. The leads, the precordial leads, are arranged in a similar fashion from lead V1 all the way through V6. Suppose you've got an infarct that's happening over here. None of the leads are actually good enough to take a look at that infarct. Let's illustrate the sternum over here. and you can see the normal positioning of all the precordial leads from V1 to V6. If you are suspecting a right ventricular infarct, what you can do is you can just use right-sided leads. You can take up all the precordial leads and place them in a similar fashion as illustrated over here. So you take V1 like this, V2, V3, and all the way to V6 onto the right side of the chest. And this time, what tends to happen is that the anatomy of the leads is more or less towards the right side of the heart. And if there is an infarct, you will see ST segment elevation in the leads which are right-sided. Let's do some practice ECGs. So you've got this ECG which has ST segment elevation in leads 2, 3, and AVF. You compare it to the PR segment, the TP segment, and you can see that there are ST segment depressions in lead 1 and lead AVL. This is an inferior wall STEMI with reciprocal changes in the lateral leads. Let's look at the next ECG. So you've got ST segment elevation in lead 2, lead 3, more or less it's the cannonball appearance of the ST segment elevation over here, and you've got depressions in lead V1, V2, and AVL. Remember the concept that if there is ST segment depression in lead V1, a mirror image of that is that an infarct is happening at the opposite aspect, which is the imaginary lead we thought. So, in reality, this is a posterior STEMI, which we can see over here as ST segment depression in V1. So collectively, this is in the inferior region and in the posterior region. So we call this an inferior posterior STEMI. The next two ECGs are going to be from the same patient with a difference of 30 minutes in between. You can see that there is minimal ST segment elevation in lead V3. And at the same time, you can see T-wave inversion in AVL, which is very important. T-wave inversion in lead AVL is actually important because it is supposed to be the forgotten lead, and not a lot of people look at it. But it is an important precursor to a STEMI in certain conditions. The same patient had another ECG, which was taken 30 minutes later. You can see that there is now ST segment elevation in lead V2, which was not present previously, and that there is T-wave inversion in AVL. This was basically a septal infarct because of the presence of ST elevation all the way from V1 to V3. Let's look at the next ECG. So you've got ST elevation in leads V3, V2, and V4 all the way to V6. A little bit of ST elevation in lead 1, AVL. So these are basically the anterior and the lateral leads. So the distribution over here tells us that this is an anterior lateral STEMI. Let's look at this ECG. This ECG was from a patient who was pain-free at the moment. This is Valence Syndrome, and you need to understand the pattern for this. So number one, you have a pain-free ECG. Number two, you've got preserved R wave progression in that there is no delayed or loss of R wave progression. You've got deeply inverted T waves, or another type of Valence syndrome could be biphasic T waves in the precordial leads. And the last one is that this is indicative of critical LAD stenosis, and it is a STEMI equivalent. Let's look at the ECGs. You've got preserved R wave progression, tall R waves. You've got deeply inverted T waves in the precordial leads. This is known as Valence Syndrome. Let's look at these. So precordial lead V3, deventer T waves, another STEMI equivalent. Number one, you've got ST segment depression. You've got a early takeoff which merges with the T wave. And you've got a hyperacute T wave which is quite tall as compared to the preceding QRS complex. Combine these three together and this is known as a deventer T wave, and this is also a STEMI equivalent. The last thing for today is going to be this page, which is basically the Omi Manifesto. There's a couple of things here which are going to be discussed in other videos, in upcoming videos, but it basically talks about how you can diagnose an occluded myocardial infarction in the presence of minimal changes, in the presence of a left bundle branch block. At the end, I'd like to point out that with any amount of ST depression in AVL, any ST elevation in the inferior leads is an MI until proven otherwise. Thank you so much for watching. Don't forget to like, share, and subscribe to the channel. As always, feedback and questions are appreciated, and have a good day.